Hi, everyone. First, I want to apologize for not being there in person. It was really out of my control, but I will definitely be there next year. So, my presentation is about facial rejuvenation in general. So, I try to include many of the procedures that we perform at Skin Experts. I'll start with the basic chemical peels. They are classified according to the depth of penetration into the skin. Superficial peels produce injury limited to the epidermis, with medium depth peels were penetrating the papillary dermis to the upper reticular dermis, and deep peels penetrate to the mid-reticular dermis. There are so many examples of superficial peels. At Skin Experts, we use glycolic acid, salicylic acid, TCA as well, or trichloroacetic acid. Of these peels that you can see here, only glycolic and pyruvic acid need to be neutralized, and you do this either by sodium bicarb or by removal with water or saline. You do that as soon as you get the endpoint of erythema or when the patient reports that there's quite some burning. Sometimes if there is none of the above, you can neutralize it after 5 minutes. When it comes to TCA, according to the percentage, you are reaching a specific layer of the skin and the depth of the peel changes. TCA 10 to 30 or 35% is considered superficial. More than that is medium or deep. With TCA, the endpoint is frosting, and it corresponds to epidermal and dermal protein denaturation. Just note that TCA penetrates slowly, so you have to wait a few minutes to assess the frosting endpoint because you want to avoid overcoating. And there are three levels of frosting, as you can see in this picture. You can have a light reticular frost with a background of erythema. You can have a confluent light white frost with background of erythema, or you can have the solid white frosting without the erythema that you can see in the last picture. We also perform TCA cross, where we basically use a Q-tip or sometimes a cannula. We put it in the depressed scars, and this will basically cause frosting in that spot. A few days later, you will have crusting, and then the crust will fall. You have to educate your patients that you might have PIH or post-inflammatory hyperpigmentation, which can last for several weeks. And I've had it in a few patients, but honestly, they didn't complain about it because I had told them already. And of course, you need several sessions. At Skin Experts, we also love the yellow peel for pigmentation, melasma. What I love about it personally is that it's only one session. And from one session, as you can see in these pictures, you really get amazing results. As for the medium depth peels, historically they were performed with TCA 50%, but the problem was that there was uneven penetration of the TCA. Sometimes they had PIH or scars. So a safer way was later used, which is to use a chemical agent first to induce epidermolysis before you apply the TCA 35%. And this allowed for a more predictable and even penetration of the TCA. And finally, here we can see the deep peels. For the sake of time, I will not go over them. Of course, I don't need to tell you that with chemical peeling, sun protection is essential before and after the procedure. They have to use a good moisturizer. If they have history of recurrent herpes, you want to prescribe Valtrex or Valcyclovir for 1 week. And it's very important for them not to pick or peel the skin that is exfoliating. Moving on to another favorite treatment at Skin Experts, which is microneedling. With microneedling, you are creating microchannels, and this is a controlled skin injury that will stimulate the dermal wound healing cascade and collagen production. And depending on the device you're using, you can reach up to 3 millimeters in depth, and you can adjust the depth based on what you're treating and the area that you are treating. In general, thicker or more fibrotic skin requires deeper penetration. And your endpoint, of course, is the pinpoint bleeding that you can see here. You can use either regular serums with microneedling, or you can combine it with, for example, PRP, growth factors, exosomes. For example, in the first picture, it was combined with PRP and growth factors, the second one with growth factors, and in the last, with a regular serum, but a chemical peel, the yellow peel in this case, was done several weeks before. So I know this presentation is about facial rejuvenation, but I just wanted to know that we're also using it on the scalp for androgenetic alopecia. This is a patient of Dr. Tuma and mine, and we did 3 sessions of PRP with microneedling based on, of course, the literature, and the patient got really good results. Moving on to RF microneedling. Most RF devices are bipolar. However, this is not the only difference that you'll find between the different devices. As you can see in this table, the needles can be insulated or non-insulated. Some provide different lengths of needles. Some will allow you to have a live feedback for the temperature and the impedance, so you can make sure that the treatment is safe. So there are so many differences. At Skin Experts, we have experience with both Morpheus 8 and Genius from Lutronic. What I like about Genius, which is at the end of this table, is that it allows you this live feedback. So you know when you're too high or when you're not in direct contact with the skin. So I really like that. I decided to show you this picture. It's not the face, but I was really impressed by one session of microneedling RF. Of course, the stretch marks are still red, which makes the treatment easier, but this was after one session. Now, if we want to compare microneedling RF to lasers, of course, with microneedling RF, you're using electrothermal energy versus the photothermal energy in lasers. They are chromophore independent, which makes them safe even for darker skin types. But of course, they can have side effects, and they have little to no downtime. So the erythema usually subsides relatively quickly, especially on the face. Moving on to lasers, I think personally, and for many of my colleagues, it's our favorite treatment. We do offer several lasers, from the vascular lasers, which can treat facial capillaries, conditions like rosacea, even the veins under the eyes. We also use non-ablative lasers. For example, in the first video, you're seeing the non-ablative laser for eyelid rejuvenation. In the second and third, we're using the thulium or the erbium glass. The nice thing about the non-ablative laser is, of course, the minimal downtime. But we also like to use our ablative lasers. We have the erbium. We do not have the CO2. And of course, here it's very important to tell your patients that there will be downtime, several days, usually around 7 in 1 week. And finally, of course, we do offer pigmentary lasers to treat sunspots, freckles, and for overall brightening of the skin, and of course, treatment of melasma. So now we move on to skin boosters. These are substances that enhance or stimulate the skin's natural function. Traditionally, boosters referred to HA boosters, but nowadays it includes other substances as well, and I will discuss some of these. But to start with HA boosters, of course, we all know the benefits. They supply moisture, they have antioxidant effects, they can provide a plumping effect, and they can enhance collagen production. In fact, studies have shown that injected HA will absorb the moisture from the ECM. This will expand the overall volume and will lead to stretching of the fibroblast or fibroblast elongation. This will initiate the expression of growth factors, which will lead to more collagen production, and it will also increase the production of tissue inhibitors of MMPs, which will reduce collagen breakdown or degradation. And clinically, this is of course reflected by an improvement of skin quality and hydration. There are different types of skin boosters. You can take a picture if you want to. Personally, I use Profilo, I use Jalupro, I also use Volite. The differences are if the HA is cross-linked or not, and of course the concentration, and some of them have additional ingredients added to them. Personally, how do I choose? So if the patient has an event, it's her wedding, and she likes a plumping effect, I would go for a non-cross-linked, higher concentration, higher molecular weight HA like Profilo. If the patient doesn't care about the initial result, she wants a longer lasting result, I am more likely to go for Volite, for example, which is partially cross-linked, but has a lower concentration and less of a initial plumping effect. Now, moving on to the trend right now, which is polynucleotides. So PDRN is a complex of deoxyribonucleotide polymers with chain lengths ranging from 50 to 2,000 base pairs. It is derived from the sperm DNA of salmon. PN, on the other hand, has a longer chain, and it may include both RNA and DNA, and it has a higher molecular weight. Here we have a table comparing both because I really wanted to see the difference between both. Some companies come to you and they tell you we are PN, not PDRN, and they're proud of it. So I wanted to see why is it important. Basically, the source of PN are the tissue of the testes, whereas with PDRN, it's sperm cells. And as we said, the chain and the molecular weight are longer and higher in PNs compared to PDRNs. In general, PDRN is more studied in wound healing and tissue repair, whereas PN is gaining popularity more in anti-aging, and it is being shown to have longer lasting results. Of course, with polynucleotides, you're not injecting the sperm of salmon like social media wants patients to believe. There is actually a whole sophisticated process of extraction, purification, sterilization. So you are just injecting this DNA without, of course, the sperm. So as for the mechanisms of action, there are two different ones. For the sake of time, I'll quickly tell you that in the first one, the adenosine receptor stimulation, you will have an increase in transcription factors and growth factors involved in angiopoiesis. And the final result is a boosting or stimulation of pathways involved in wound healing, in regeneration, and new vessel formation. And you have the salvage pathway where you're going to have new DNA synthesis. Of course, when it comes to the injection technique, it's intradermal and you can use a small gauge needle. You can use the cannula as well, and there are some studies about cannulas, but of course, the needle is more popular because you really want to be intradermal. As for the number of sessions, you can do one session every 2 to 4 weeks for a total of 3 to 4 sessions. When it comes to skin rejuvenation and wrinkle treatment, what I want you to know is that there are studies that are being published. So we have more and more studies. I'm not going to go over them, but for example, here we have a study on crow's feet, and there are studies that involve histopathological findings to show the increase in collagen production. We also have studies on the full face. We have studies where PNs were combined with microneedling RF or even lasers or HA. We have studies on scars with good results, as you can see here, and in these post-thyroidectomy scars. And these are the different types. At Skin Experts, we're currently using Plinest, which is Italian. I'm also using the Chroma in Lebanon. And so far, to be honest, patients are happy. As you can see, there are differences in the concentration, and also if it's PDRN or PN, and in the volume of the product that you have in the syringe. So finally, I'm going to move on to the last part, which I'm going to talk about biodegradable polymers, but I'm not going to talk about PLLA. I'm going to talk about PDLLA. So I don't know about you, but some patients are asking me about Estafil and Juveluc, which are now trending, especially in Korea. So PLA or lactic acid, of course, we know it's the basic component of PLLA, but when it comes to PDLLA, it's a copolymer of the L and D forms of PLA. This is a table comparing PLLA and PDLLA. PLLA is hemicrystalline with a regular chain structure, whereas PDLLA has an amorphous structure with an irregular chain. What's special about it is that it has a porous structure, and this allows it to be degraded more easily compared to PLLA. Also, the soft tissue volume augmentation of PDLLA can be described in two stages. You have the initial volume due to the PDLLA particles, and then you have the volume increase later on due to the collagen stimulation. Why is that? Because as you can see here, the microparticles have multiple pores. This means that it occupies a larger volume than PLLA for the same weight, so it has a direct volumizing effect, and this is in contrast to PLLA like Sculptra. Injectable PDLA is also supplied as a lipophilized powder, as you can see here. It's, for example, it's 154 milligrams of PDLA microparticles with 46 milligrams of carboxymethyl cellulose. As for the mechanism of action, I will skip, but just know that there is a reduction in collagen destruction and increased collagen synthesis. There are many studies now that are being published about it when it comes to hand rejuvenation, face rejuvenation, and the results look good. However, some complications can occur just like with PLLA. And for example, these include granulomas and non-inflammatory nodules. This is the case of a 45-year-old lady who presented with nodules 4 months after PDLLA injections. A physical exam revealed multiple nodules, and it was confirmed by ultrasound as well. She received an injection of intralesional triamcinolone as well as low-dose oral prednisone for 5 days, and the nodules resolved, thankfully. Other more serious complications can occur, for example, here, multifocal strokes and vision loss in a female that was injected in the nasolabial folds and the infraorbital region. This is another case, this is another case with multiple branch retinal artery occlusion following injection of PDLLA at the glabella. I would never inject it in the glabella, to be honest. Yeah, the studies are really promising, but we definitely need more studies to assess the safety, the efficacy, and of course, to compare it to PLLA. So this is the end of my presentation. Thank you so much.
Any questions to Dr. Samar? She's on standby. Hi, Samar.
Hi, everyone.
First question for Dr. Samar. You put many options for skin rejuvenation. So you can order the best, then the less this. In a patient, she has many problems in her face, like pigmentation, white bars, and many problems. What is the best to start with?
I mean, you have to prioritize. You have to see first what the patient is what's bothering the patient the most, and you start with that. You also have to take into consideration the downtime that the patient can afford. If it's summer, for example, I wouldn't go for a very strong peel. You can also go for example, if it's summer, you can go for the non-ablative lasers. You cannot go for the ablative lasers. So you take into consideration the main complaint of the patient, the season, of course, and of course the price. The patient has to be aware of the prices and how many sessions she has to come in for. Some patients come just for one visit and then they have to travel. So sometimes we have to be more aggressive just because the patient is there for only one session.
Okay, in combination of treatment like biostimulator.
Of course, combination is always better, especially when we're dealing with scars.
Okay, so my question, the biostimulator like radius, say, or calcium hydroxylase and polylactic acid, it's any interact with microneedling RF, it's just like heating like that. So we can do in same session, or we should make like interval between them?
Personally, I am known to be a safe doctor, so I always try to be as safe as possible. I always tell my patients to space them 2 weeks apart. So I don't tend to enjoy, although I know many of my colleagues do it and it's fine, but personally I prefer to space them 2 weeks apart.
Okay, thank you. And for Dr. Rami, if we discover the complication later, like necrosis, the patient, he came with necrosis, what should I do?
You start off by contacting your insurance company. But on a very serious note, there are ways of dealing with delayed. If we understand necrosis, basically it's the lack of blood supply, which means lack of oxygen. We do have now here in the UAE hyperbaric oxygen devices that you could send the patients to and deal with that. What would you think?
Yeah, clearly, if you're at the necrosis stage, it means, either the thrombosis was so bad or there has been such a delay in diagnosis, or sometimes, patients travel and then they tell us late or something. But at that stage, definitely hyperbaric oxygen chamber might help restore some of the skin integrity, or there might be a need for excision, Dr. Narwan. Dr. Dora, if there's necrosis, it's hard to restore. We've had some experience with the Beirut port explosion. Almost necrotic areas that actually we've been able to revive with PRP sessions every day or two. Debriding when the necrosis was superficial, so debriding that area, with the scalpel. And then creating, with the fractional laser, creating some holes so that the skin can re-epithelialize from the perifollicular area. So if it's a superficial necrosis, there is hope. If it's a deep necrosis, you're in trouble. Dr. Ali, Dr. Fatma, no questions? Everything's clear? Okay, good. Any questions to Dr. Zainab? Yes, please.
So you mentioned comparison between PDLA and PLLA, and of course now that PDLA has become much more popular in the market, you mentioned the complication of one case with blindness by injecting it in the glabella. I wouldn't ever inject it in the glabella as well, but haven't there been any cases reported with PLLA having the same side or the complication?
Yes, so there are cases reported with PLLA as well. But in general, when it comes to substances that cannot be dissolved, you always want to be safe and
Absolutely.
avoid high-risk areas that Dr. Rami mentioned.